more often than not, what we do is we do a little skin prick on the arm or on the back to detect certain different allergy types and see what response our patients have to that particular allergen. For patients who do not want to undergo that or who cannot undergo that for various reasons, we do some testing of some blood work to see what type of allergens our body is responding to, how, has our body responded to certain allergens in the past and how vigorously. And it's the allergist who does this quite elegantly in their office. So this is this particular patient, and I hope this video works well. But you can see that this patient, here's the septum, and this is polyp, inflammatory allergic polyp coming off of the septum, completely filling the nose and sinus. And sorry, the video is a little bit choppy, but you can see that the entire sinus is absolutely filled with this particular polyp. And this is something that's very useful to know because I can go to my allergy doctor and say, hey, my patient has a ton of allergic looking polyps inside their nose and sinuses. So this is the same patient. We treated the patient, and then they came back later, and sure enough, there's extensive polyp that has returned, filling all the sinuses. And the sinuses, this is a CT scan that we do when we can't see quite everything with our little camera. We do a CT scan to get us a better picture. And sure enough, all of these sinus are filled with this gray, inflamed looking polyp. And you can see that this black here, this is air, same as the air outside of the patient's head. You want air in your sinuses. My wife always calls me an airhead. I think she's probably right. I hope she's right, because you want to have air filling your sinuses. And so this in particular is a scan of someone who's got significant allergy burden in their sinuses that's causing sinusitis. So what do allergies do to your nose and sinus? I think that this is the next critical jumping off point for what to do next with someone like this. And what we've discovered is that prolonged and untreated allergy can not just affect your sinuses, but can actually affect your throat. It can affect your lungs. And here's that fuel, kind of put fuel to the fire, if you will, for the lungs, for asthma, for cough, for bronchitis, for cough and congestion in the throat, for postnasal drip that irritates the throat, and of course, as we just discussed, the point of this lecture, for the sinuses and nasal cavity. And so not treating your sinusitis has long-term significant impacts on our patients. And so here is sort of what I was alluding to or discussing at the very beginning of this lecture when I showed you all those different polyps. And I said that 10 years ago, when we looked at these polyps, we used to say, that's just an inflammatory polyp. Let's treat with steroids, for example. What we can do now is under the microscope, we can actually identify what type of polyp is what. For example, what polyp is a Th1 or neutrophilic inflammatory polyp? What is an eosinophilic inflammatory polyp? And sure enough, what we've discovered is that we can correlate these findings, which tell us if someone is allergic to something, to our endoscopy, that picture that we took in the office of the patient's sinus, or a CT scan, that scan that I showed you before, where all the polyps are right in the middle here. And what we've discovered is that patients with polyp in that location, with CT scans that show inflammation in that location, tend to be highly, highly, highly allergic. And while many are younger, many don't have to be. In fact, we have many older patients who have chronic sinusitis with allergy-associated polyp that presents in different locations. And so this is just an interesting example of a particular brand of polyp called central compartment polyp that is so strongly associated with allergy that it almost is treated one and the same. And a lot of the data that we have been able to gather comes out of Emory University, where I did my fellowship, and we did computational fluid dynamics studies that looked at the airflow going into the nose and in patients who had sinusitis and allergy, and found that it's the nature of that airflow that leads to all those allergy particles depositing in one location versus the other and leading to sinus symptoms. And so here you see those very distinct polyps and their very distinct location. And we discovered that this is a strong association with allergy, and we have to treat these patients aggressively for their allergy symptoms. We talked a little bit earlier about the diagnostic criteria for sinusitis and allergy and how closely associated they seem to be. And that close association explains a lot of the research that we've been able to do in treating both of these diseases. And sure enough, we found that patients with sinusitis, many have allergy. And if you treat one, you can help the other. And we even went a step further, and we found that if you treat patients with sinusitis or patients with bad nasal associated allergy problems, you can actually help their lungs. In fact, there's a great study out of the University of Pennsylvania by David Kennedy that showed that if you open up all the sinuses, you clean out all the sinuses, you can cure, in some cases, patients with asthma or bad lung disease. And the outcomes, in fact, from those procedures, from medical interventions, or even from surgical interventions, have demonstrated that patients with this particular syndrome, namely allergy-associated sinusitis, do incredibly well. They have great outcomes as long as you plug them in to an allergist. You treat them as a team with your primary care doctor, your ENT, and your allergy doctor. You can keep the patient's complaints of allergy and sinusitis beautifully under control. And this, I think, just speaks to how advanced we've come in the management of sinus disease, of allergy, of chronic nasal and lower airway complaints. And I think we've certainly made it well past the ancient way they used to do ENT evaluations. This is someone pouring molten lava onto the nose and hammering a chisel into the nose. This is not sophisticated by any means. So I think we've come a long way, and we can do a lot of really great things for our patients. So actually, this patient did require a revision procedure, and this is the revision cavity. It shows already that there's a little bit of swelling that can occur with allergy, but this patient has been under beautiful control and has had a remarkable return to her quality of life. And it's just awesome to see someone who was so debilitated, who couldn't take care of kids or go to their job and feel like they're, not feeling miserable, not having goop come out their nose and constantly itching, doing that allergic salute that I told you all about, rubbing their eyes. This is someone who we can put back into society, and I think we're really proud to be able to offer that. So with that being said, allergy and sinusitis certainly coexist. Managing inhalant allergies aggressively with nasal salt water, or nasal, we call it nasal toilet, just rinsing out the nose and irrigating the nose, putting a proper nasal routine that includes antihistamines or steroids, and even putting patients on oral antihistamines, oral steroids, and in some cases, oral antibiotics, and in very select cases, surgery for those who failed those medical routines. And of course, working with our allergy doctors, our lung doctors, is vital. So really honored to be able to speak to you all today. I think that it's a real privilege. Thank you, Sandra, for setting this up. This is truly a wonderful thing that you're doing for the community. And if there are any questions, I'd be delighted to answer them. Or you can also email me with any questions you may have. I'm also happy to answer those there.
Thank you, Dr. Hellman. Great presentation. Really amazing. I think, like, for example, I didn't know anything about, those polyps and things like that. I always thought polyps belonged in the colon, to be honest. And now it's surprising to know that we can have them in other parts of the body. So I don't see many questions here, but I have a question. Do you react the same to all allergens? Like, for example, you showed that picture of the lady and pretty much you flared up with every allergen. So do you have the same reaction to all of the allergens, or it can be different?
That's a great question. Everybody has different responses. I have allergies, but they're under control. If I use my handy dandy bottle of Flonase, which I'm addicted to, I'm joking. This is not addictive by any means, but Afrin, I should mention, don't use Afrin. That is quite addictive. But if I take my Flonase, I'm fine. I can function. I can do my job. But there are some, and this again speaks to what I was mentioning before, which is that we don't, in looking at one person's nose versus the other, it's sometimes hard to tell how someone is going to respond to different allergies. And some people respond very aggressively, very, very vigorously, and we don't know why necessarily. We just know that they do, and we know that we need to take care of it. What we've discovered through a lot of research is that the behavior of people's immune system tends to drive the responses to allergens. And actually, we use medications in patients who have very aggressive disease that suppresses the immune system to reduce that response. But we can't keep patients on that forever. So prednisone is a great example. of something we give patients to reduce the immune system's drive to cause allergy and inflammation. And it may change with time. I mean, that's I've been skin tested, and if I were to be skin tested today compared to how I was growing up in rural Oregon, you know, 30 years ago, it would be a night and day difference. And that's because our immune system tends to relax with time. It's called immunosenescence. And so that's the other interesting thing driving this.
Uh,
Um,
and have you heard of nasal chrome, an over-the-counter medication?
Yeah, so there's certainly a lot, and also I want to make sure I also address one question from the audience as well. But yeah, so cromolyn medications that prevent the release of mast cells. Those are agents that basically block the mast cells releasing their histamine. The histamine is really what causes the rhinitis, the itchiness, and things like that. But the gold standard actually is not that medication. The gold standard, believe it or not, and this is from extensive data, is nasal steroids. And there's a whole bunch of different nasal steroids. We have to make sure that you're a candidate for nasal steroids. All medications have side effects. And I always say, look, some of these are over the counter. Nasal Cort's over the counter, for example. But just make sure that you are a candidate for that before trying that. I mean, technically, Afrin is over the counter. And Afrin, is something I think that should be a prescribed medication. But to answer your question, I think that's helpful in some patients. But the gold standard is the primary therapy should begin with a nasal steroid like Nasacort, budesonide, or fluticasone or Flonase. And then secondary, it should be an antihistamine. Azelastine is a classic example. And actually, we have a new product on the market. It's a little bit expensive, so I usually prescribe them separately, called Dimista, which is azelastine and Flonase together. And I saw Oh, I saw a question from
Yeah,
Yadira.
here is another one. How long would tests take to come up with a diagnosis and treatment before relief?
That's a great question. It really depends on, the allergy, really. I mean, or what the complaint is, whether it's sinusitis or allergy, or even in both. I mean, it can take more than one visit to get the information we need. But the great thing is that so my system. I'm from I work here at Montefiore Nyack, and I'm also at White Plains Hospital, and we have a great group of allergists who see patients immediately. I triage in terms of what I think they need to have done. And I think that's the big advantage. I feel like I'm cheating sometimes with my scope. I mean, I have all these really smart medical doctors, not to say that ENTs are not, I like to think we are. But they have to really put their thinking caps on. They're really great diagnosticians. I take my handy dandy camera and I just look inside your nose and sinus, so I'm able to get enormous information from that. So even in one visit, I'm able to come up with a good plan that can give you symptom relief. The real question then is, is this just a blanket therapy? I mean, are we just suppressing the symptoms? How can we drive to the heart of the matter? That can take a little bit more time. And that can include seeing an allergy doctor to get allergy tested. I mean, you have to get the skin prick testing, you have to get the blood work. It may mean if I see signs of extensive sinusitis, I may require you to get a CT scan. The number of visits really depends on the patient. And I think that kind of speaks to modern medical approaches. We're really tailoring our therapies to the individual patient. It's very patient-centered, which means that there's not one size fits all for everybody.
And one more question is, why do you have to be tested on the skin and the blood? Is one better than the other, or how are they different?
That's controversial. I would say most would prefer skin testing. I mean, some individuals just can't be tested on the skin. There are certain patients who respond the same way to everything. There's some who may have had what's called anaphylaxis. And you say so blood work is easy, it's safe, it's one little poke, it's a very small amount that we need. But again, it varies on the allergies. And then there's some who say, well, you're telling me every time you're around your dog that you get this particular reaction. That can be enough information at times to help triage what next steps that we could do to make you feel better. Again, these exposures are things that are so common in our day to day. Dust mites, things as simple as cleaning your sheets, double cleaning your pillows, putting in a special dust mite pillow, putting in a air purifier and a humidifier could be helpful to reduce that burden. But these are things that are around us all the time. Cockroaches. If you've, I grew up on a farm in Oregon, and I made the decision to live in a 700 square foot apartment in New York City. There were cockroaches, in abundance, in this area, and my allergies really flared up. Dogs, pets, we all love our dogs and pets, but especially certain dogs that have a high dander burden, they can really increase your symptoms. But the next step would be to get a hypoallergenic animal, or to get rid of the dog and pet. You can't really do that, and so that's where medication really helps out for patients with those problems.
Can you develop allergies over time?
So you can. I mean, usually the incidence of allergy tends to go down with time. So usually, the overall incidence of allergy tends to diminish with time, but it's certainly possible. Or you may have had an allergy to something, but you just didn't realize it, and then you move into one location or the other. And actually, there are some great examples in the American South of that happening, where certain individuals are predisposed to severe reactions to certain types of pollen. And actually, the reactions are so severe, it creates polyps that can actually look like tumors. In fact, in many places, they get a scan and people think that it's a tumor. And it looks like that because it can sometimes even push the eye or push the base of the skull out. It's really remarkable how aggressive of a reaction it is. And that is a local environmental problem. And actually, some of the patients we used to treat down in Atlanta with that problem, we used to say, hey, consider moving out of the state to avoid that particular exposure. So to answer your question, it certainly can happen, or it can happen because you had that predisposition and then you moved to a different location, then you got that problem. But typically with time, allergens tend to diminish.
And the last question, Dr. Herman, is who is this adorable teddy bear on our screen?
Oh, that's my son. Yeah,
He's so cute.
he's great. He doesn't love that outfit. That's
Oh no, it's so cute. Oh my God, like
it's
I want
it's
to
tough to convince him out of that outfit, but
Oh,
or into that outfit. But great. So anyway, look, I really appreciate you all. Sandra, thanks so much for setting this up. Feel free to email me if you guys have any questions. I'm always happy to wax poetic. I love this topic. I think it's so interesting to take care of the patients with this, and looking forward to the next webinar. So I'll talk
thank
to you
you
all soon.
so much, Dr. Herman, and to everyone who joined us today. I'll see you next week.
Sounds great. Talk to you all later. Bye.
Bye bye.